Thank you. My name's Sebastian. I'm a consultant in Sheffield. So I'm going to talk about the side effects that you can get on these tyrosine kinase inhibitors and how we try and manage them. So, as you've heard prior to 2001, CML was a really serious disorder and life expectancy was reduced. But with these tyrosine kinase inhibitors, things have really changed. So in the UK, there's imatinib, there's nilotinib, there's dasatinib, bosutinib, and ponatinib. So I'm going to talk a bit about each TKI, and I'm sure a lot of you will have these symptoms, either very severe or what we call low-grade toxicity. So imatinib is what most of you will be on. Most of you would have started on this, and we've got most information on imatinib. But most of these tyrosine kinase inhibitors, they cause skin rashes, they cause fatigue, they cause lots of symptoms, but they all add up, some of these symptoms. So they're not extremely severe, but the cumulative effect of these side effects can affect your quality of life. And I can see people smiling and nodding. So it's there. Sometimes a doctor may not always acknowledge it because he'll be looking at the full blood count, he'll be looking at the molecular tests. But in the background, what I tend to find is patients tell the doctor, they tell the CNS nurses, and they tell the pharmacists. And so sometimes in clinic, when someone comes next time, I've understood what's happened because the pharmacist has written lots of things about compliance and all the small side effects that people have, but sometimes don't mention or think it's trivial. So imatinib does have lots of side effects. So when you tell the doctor what sort of side effects you have, the doctor will try and grade it. So he'll be scribbling away in the notes. He'll be trying to work out whether it's a grade 1, a grade 2, a grade 3, or a grade 4. So when you speak to a doctor, if you've got a grade 3 or grade 4, they'll stop the drug. So that's what all that scribbling is about. You know, when you're telling us, you know, side effects of things like fatigue, we're trying to grade how serious this is. We would tend to try and continue if you had just had grade 1 side effects. Obviously, if you had grade 3 or 4, we would discontinue. But the side effects that a lot of people complain of, have symptoms of, are swelling, so swelling around the eyelids, swelling around the ankles, nausea, muscle cramps, musculoskeletal pain, so generalized muscle aches, joint pains, diarrhea, skin rashes, fatigue, headaches, tummy discomfort, and joint pain. So that column on the right in single figure shows that it's not common to have very severe side effects, but but the column in the middle show that a lot of these side effects are very prevalent. They're above 50%. So a lot of you will have these symptoms of nausea. So when you tell the doctor you have nausea, they'll try and give you an anti-sickness medication. If you have muscle cramps, they'll try and give you painkillers. They'll check your calcium and your magnesium, your salt levels, to see whether they can try and explain why you've got muscle ache. Sometimes, you know, the salt levels are all normal. In terms of diarrhea, again, that's very common, and doctors will try things like loperamide to try and help your quality of life. Skin rashes are also very common as well, and fatigue and headaches and tummy discomfort. So this is a patient with imatinib-induced skin rash. So as I was saying, if you've just got a mild rash, we try and manage that with creams, steroid creams, antihistamines to try and stop the itching. Obviously, if it's very severe and it's affecting your whole body, you know, we would stop it and see whether it improves and then restart it at a lower dose and see whether things improve. This is periorbital edema, where sometimes when you start imatinib, you can get these swellings around the eyelids. They can sometimes be very troublesome to treat, and we try and use water tablets for the fluid retention and try and consider a dose reduction if it's very, very troublesome, or we would switch drug if it's really affecting your quality of life. So in terms of management strategies, people have skin rashes, so as I say, we use steroid creams, we use antihistamines to try and stop the itching. In terms of the fluid retention, sometimes people can get around the ankles, we use water tablets. In terms of muscle cramps and generalized muscle aches, this is very common in clinic, and you know, we try and encourage people to drink plenty of fluid. We check their calcium, we check their magnesium, we check their potassium. What we do know about imatinib is sometimes your phosphate levels can be low, and that can cause your calcium levels to be low. So over a course of time, you can get reduced bone mineral density. So, you know, we will be checking for things like phosphate and calcium. But sometimes we just can't find the cause, and we know it's the drug. And sometimes the analgesia can range from paracetamol to morphine, and it can really debilitate people. But what we do know about imatinib is it's being used the most of all the TKIs, and we see that the severe side effects, what we call the grade 3 and 4 toxicities, tend to decrease after 1 to 2 years. That's not to say that the other side effects that aren't severe but are present, always in the background, affect your quality of life. And we also know that with imatinib, there's been no increased risk of other cancers. So there was a study called Enrich, and this acknowledged that there were lots of people who just didn't agree with imatinib. It was affecting their quality of life, it was affecting their compliance, and something had to be done. They wanted to try something else because, for all intents and purposes, they wanted to comply, but it was just affecting relationships, it was affecting their quality of lives. So it's really important to inform your doctor about all these side effects. Confide in the CNS nurse as well, because messages will get back to the doctor. The doctor is always speaking to the CNS nurses, and he's always speaking to the pharmacists. They will hunt him down. I can assure you, the nurse will find the doctor. So in this study, they switched people to nilotinib, and nilotinib was found to be a very suitable alternative. So I'm going to talk about nilotinib now. So in Sheffield, we tend to use nilotinib after someone's had imatinib. We either use nilotinib or dasatinib. We rarely use a second-generation TKI first off. So large studies in looking at nilotinib, again, have shown that there are lots of side effects, but the very severe side effects that necessitate stopping the drug, thankfully, are in single figures, the grade 3 and 4 on the far right. But I'm sure a lot of you have experienced these other side effects of rashes, headaches, nausea, itching, hair loss, muscle aches, fatigue. They're all a common thread for all these drugs: muscle spasm, lower limb swelling, eyelid swelling, and swelling around the eyes. So we also know that in the long term, nilotinib can cause heart problems as well, and that's something that Prof. O'Brien alluded to as well, and it can cause ischemic heart disease and furring of the vessels in the legs when compared to imatinib. So when ENEST-ND, this study looking at nilotinib and imatinib, they noticed that the dose and the drug nilotinib had an increased risk of heart problems and furring of the arteries. So when you start nilotinib, the doctor will be checking your lipid levels, your cholesterol, your triglyceride levels on a regular basis. They'll also be checking your glucose levels as well. And they'll also be checking things like HbA1c, because people who have nilotinib, they can have slightly higher blood sugars than people on imatinib. And that's well recognized. We'll also be checking things like your salt levels and your magnesium levels to reduce heart problems. It's also really important when you consider starting nilotinib that you have a baseline cholesterol. Someone does in the CML clinic in Sheffield. I do clinics with a pharmacist, and they are really brilliant. So they work out this Q-risk score. So, that's based on your cholesterol, your postcode in Sheffield. This is really interesting because I played with this, and depending on what your age is, what your postcode is in Sheffield, I don't know how it's worked out, but if you, just by having an S6 postcode as opposed to an S10 or an S11 postcode, your cardiovascular risk changes. If you know Sheffield, S6, S5, there's high levels of deprivation and smoking. And we also check ECGs before we start nilotinib. And the doctor will be scribbling down what your heart rhythm, what your ECG looks like. And we encourage everyone to have their blood pressure, cholesterol and glucose checked, on a regular basis, because nilotinib can, as I say, cause furring of arteries. So we need to treat any signs of diabetes or high blood pressure. They need to be treated while on this drug. So certain studies looking at patients on nilotinib, called the ENACT study, that showed that people who start nilotinib, they can have, after about 7 days on this drug, they can have slightly higher blood sugars. And so it can take up to about 21 days for these slightly higher blood sugars to be seen. Diabetic patients need to be counselled very carefully regarding what is the best tyrosine kinase inhibitor to take. Nilotinib can be used in diabetics, but you need to really monitor the blood sugars. And we also know that the cholesterol levels, will rise. So when I say rise, they don't rise massively, but they do rise. So in Sheffield, there's a really big thing about metabolic syndrome. So we're trying to get our patients on nilotinib to go to specialist nurse-led clinics looking at this metabolic syndrome. The oncology teams in Sheffield have got a big head start on us, and they've been doing this for a lot longer than we have. So the next drug I was going to talk about was dasatinib. So dasatinib again causes skin rashes, it causes fatigue, it causes headaches, it causes similar symptoms to the other tyrosine kinase inhibitors. And these symptoms can be difficult to treat, and it's sometimes frustrating for yourselves. But specifically with this drug, we need to be on the lookout for if you have symptoms of a dry cough, you feel a bit more short of breath than normal, you have fatigue. These could all be pointing to fluid in the lung. So this chest X-ray shows the left lung field having what we call pleural fluid. So that can easily be detected when the doctor examines you and taps your back, and when he organises a chest X-ray. So studies have shown that about 28% can develop pleural effusions by 5 years. So I hark back to this idea of grade 3 and grade 4, so that's how the doctor decides how severe it is, whether to stop it or to continue it. It's very unusual that you need to put a tube into the lung to drain that fluid. If it becomes a problem, stopping it, normally stopping the drug, improves it, or water tablets and steroids. What we do know is the people who develop these problems, fluid on the lung, tend to have higher dasatinib doses. They have underlying heart disease, and I'm not sure why, they tend to have skin rashes on imatinib. And these pleural effusions can reoccur, but they can be treated with, as I say, furosemide. It's sometimes a real tricky balance if you're really responding well to these drugs, but you're having side effects, because people are living longer, but we want you to have good quality of life, because that's what we're here for. So dasatinib can also cause pulmonary hypertension, where the pressure in the vessels in the lung are elevated. So Sheffield happens to be a pulmonary hypertension centre in the United Kingdom. So I've seen a few of these patients that have been referred from other hospitals, and they can present with shortness of breath and fatigue. The incidence, thankfully, is very low and it's very rare, and this can improve once you stop the drug, and your symptoms in terms of functional ability and shortness of breath do improve. So I'll come on to bosutinib. So bosutinib again has very similar side effects to the other tyrosine kinase inhibitors, but what this drug has been associated with is diarrhea, and the diarrhea can be quite severe, and it can start within the first 4 weeks, and it can last 2 to 7 days or longer, and 10% of patients can have quite severe diarrhea, and some patients will be admitted to hospital because they become quite dehydrated, and they need to be given fluids to help their kidneys. People have found that loperamide is really helpful, either before symptoms start or at the onset of symptoms. It can also cause tummy discomfort. Most of the tyrosine kinase inhibitors can cause tummy upset, heartburn, it's important to exclude tummy discomfort due to pancreas problems as well. And omeprazole and lansoprazole can sometimes be really helpful in this situation. So ponatinib. So ponatinib is something that I tend to use before when things are not going well. The molecular tests are rising, and we're considering going towards a transplant. So ponatinib, as has been alluded to earlier, increases your risk of having arterial and venous clots. And studies have shown, again, it causes skin rashes, and it can cause cardiovascular and lower limb furring of the arteries. And clots tend to be associated with higher doses of this drug. So this drug can be given 15, 30 or 45 milligrams. So it's really important that if anyone starts this drug, that you try and try and monitor their cardiovascular risk factors, so that so people's lipids, glucose levels, blood pressures, if they're abnormal, need to be treated to try and reduce this risk of having blood clots. Ponatinib can be problematic if you've had a history of strokes and heart attacks in the past, because if you've had these risk factors and the doctor does this Q risk score that the cardiology doctors always talk about, but a lot of my other colleagues have never heard about, so the other haematologists in my department don't recognise what this Q risk score is, but when I speak to my cardiology colleagues, they immediately understand what you're talking about. And it's really important, as I say, to control your blood pressure and monitor for any blood clots. So if you're on ponatinib and you feel short of breath, or you notice you've got chest pain, or you've got swelling in the legs, it's really important to contact the day unit. So we've got to remember where we are now. So before 2000, people were treated with chemotherapy. They were treated with really aggressive treatments, and people had lots of nasty infective complications. Their counts would be low. They'd be requiring blood and platelets. Thankfully, I don't remember that, as Dr. Ewing will attest to. Since I've started haematology in 2006, I've only known tyrosine kinase inhibitors, but my old bosses like Professor Clark tell me what it used to be like before the millennium. So the adverse effects do reduce over time, but we are acutely aware that people do have these, what we call grade 1, grade 2, what we call background side effects, and they can be really debilitating. And we try and do our best to try and get on top of this. In terms of fatigue, I've tried to refer some of my patients who complain of real fatigue, and it is real fatigue, to the physiotherapist to do graded exercises. It has some benefit, but some people, you just can't predict how it's affecting them, and it's not easy to control that. But as I say, it is important to keep on informing the doctor of these side effects, because the doctor will always be looking at the full blood count and the molecular test, and he will be asking you for symptoms, because he wants to know as much as he can and help you. These symptoms can be treated. And it's also important to talk to the haematology nurses. They're always there to talk about these side effects. It's important when you pick up your prescriptions to talk to the pharmacist and let them know, because they also write in our notes as well. So I find it really helpful when I see someone the next time, if they haven't explained it to me, that the pharmacist has definitely written this down. So I can then probe more as to how I can help, what drugs I can use to try and either improve compliance, hopefully keep you on the drug if you're having a really good response, or if your quality of life is really affected by these, think about going to another TKI. It's also really important to monitor those cardiovascular risk factors. So check those glucose levels, check those cholesterol levels. Sometimes it's really fascinating when a patient comes in and they want to know their BCR-ABL level, and then they'll ask me about their glucose level and their HD and their HDL cholesterol level. They're taking part in their treatment. They know what these drugs can do, and that's so good to hear. Obviously, if the side effects are what we call grade 3 and 4, and they're intolerable, then we will stop the TKI, or stop it temporarily and start at a lower dose. And sometimes skin rashes, can improve at lower doses with steroid creams.
Thanks very much for that. We'll move on to the next talk, and Dr. Dragana Milošević from the Hammersmith is going to speak about the importance of TKI adherence once I've found her talk. I have let them know that we're going to be about 10 minutes late for lunch, so hopefully we'll be able to break for lunch between 10 past and 1:15.
So thank you very much for the introduction, and while my